This is a quick review of some of the basic principles behind continuous renal replacement therapy, CRT. Some of the things I'll be going over in this video include what is CRT, which patients will be getting CRT, the basic differences between some of the modes we use. I'll be talking about ultrafiltration. I'll be talking about dialysate. I'll also be talking about some of the things that we've learned over the last couple of years, including associating and disassociating the devices. Some of the things I will not be talking about is I will not be talking about priming the machine, shooting the machine, or recirculating the machine. I'll be talking about those in later videos. So the first thing is, what is CRT? So CRT is basic dialysis designed to work as a substitute for the kidney in patient with impaired renal failure. And the difference between IHD and CRT, which we'll talk about a little bit more about in later slides, is that it's 24/7. It is, as the word says, continuous. So who gets CRT? CRT is for the acute renal failure and the chronic renal failure patients. It could also be used for liver or heart failure patients. Rhabdo patients, we see rhabdo a lot in our patients who are overdose patients who are found down. But really, we use it more than any other unit here at Presby because of our septic shock population. In sepsis and septic shock, your blood pressure drops dangerously low. When your blood pressure drops dangerously low, it affects how fast the blood flows through your body. Because the blood flow can't flow as quickly, again, you have lack of perfusion. And the kidneys are usually always the first to go. At the same time, because the blood is going so slow, you go into DIC, where your blood begins to have little microclots. When you have microclots, it's going to slow down the blood even more, which can, and DIC can really happen with any disease process, but it is pretty prevalent in septic shock. So we put these patients on CRT. Now, the different types of CRT depend on what's actually going on in terms of fluid or particle movement. So the two real processes in which fluid and particles move through the blood are called diffusion and convection. So first I'll talk about diffusion. What is diffusion? Diffusion is the movement of solutes from an area of higher concentration to an area of lower concentration. As you can see in these beakers here, on the first picture on the far left, you see that the left-sided chamber has more particles than the chamber on the right. In the second picture, you start to see that those particles from the left start to drift over into the right side of the beaker. And then by the end of this diffusion process, you see that there's an equal amount of particles in each side of the beaker. Now, let's think of the left side of each of these beakers as being the blood and the right side as being the dialysate. In a mode like CVVH that uses diffusion, dialysate is actually going to flow countercurrent to the blood. And what's going to happen is small molecules and middle molecules are actually going to flow from the blood into the dialysate, and the dialysate is going to go out through the waistline. And, you know, when we're setting this machine up, we set this up green to green. So in a better picture here, the basic principles of diffusion and CVVH is, you know, you look at this picture, you see that the blood with all the junk in it, all those additional electrolytes, all the creatinine, all the urea is on the left side. As the dialysate flows countercurrent, separated by the filter that we use, the hope is that the dialysate has a lower concentration. So all that blood, which has higher concentration, all those particles are going to move in through the semipermeable membrane, which kind of picks and chooses which molecules actually come over into the dialysate. And then the dialysate is going to carry that right out into the waistline, and the blood will then return to the patient with less particles, including, like I said, those electrolytes that are usually maintained by normal, healthy kidneys. So the dialysate itself actually contains sodium, chloride, and magnesium. It's pretty much equal to the normal serum. It also contains potassium in it. Now, we know that potassium is one of those molecules that really climbs when we have a patient in renal failure. So we'll talk a little bit about how you choose potassium concentrations next. But the goal is that it's not going to pull over everything. Depending on the concentration, it's going to pull over exactly what it needs. And again, that semipermeable membrane helps. There is not urea or creatinine in the dialysate. Again, that's to the things that we're trying to remove by putting the patient on dialysis. So when we're looking at dialysate, the replacement fluids, I mentioned we really focus on the potassium. Potassium is really big because of the cardiac ramifications that it has if it's too high or too low. So we do have the option between 0K, which is no potassium, 2K, which is middle amount of potassium, then the 4K, which is actually closest to our serum level of K. Again, if you think about it, we like to keep our potassium around 4 in our when we're getting our BMPs. So a potassium of 4K is as close to a serum as you can be. So the higher the potassium level in our blood, we want to give dialysate with lower potassium, because again, that lower concentration, we're hoping some of that higher concentration from the blood comes out into the dialysate and then is carried out of the body. It's the way that we maintain our K, our potassium, as we're doing dialysis. So the general rule of thumb is, if your K is greater than 6, we're going to put the patient on 2 or 0K. And the difference between that is if your K is greater than 6, but you have electrolyte changes, that's when we're going to go to the 0K. When you are on 2K, you do want the labs to be checked every hour. With 0K, you want the K to be checked every hour. And you keep doing that until that potassium is less than 5.9. This is the general makeup of the dialysate composition. And again, in some of the future videos, I'll show exactly how to change bags over if you need to in the middle of a treatment. Like let's say your K drops below 5.9, you're no longer in the 2K, you want to switch to 4K. I'll show you that in a future video. But each bag is made up of all these electrolytes. And you see the main difference there again, focusing on the potassium, 0, 2 milliequivalents per liter, and then 4 milliequivalents per liter. Okay. So when we talk about convection, the other mode of particle transfer, where it's actually, with convection, the therapy or replacement fluid is the solvent. And what happens is the fluid actually gets dragged over into the across the membrane. So when we talk about diffusion, we talked about mainly the particles or only the particles coming over. But in this case, the fluid actually brings those particles with it. And some of those middle size molecules, such as uric acid and glucose, will also come over. But again, it's mainly used for those smaller molecules like your electrolytes. So this is how CVVH works. So these heavier molecules adhere to the filter, and then they'll clear out in the effluent. But the adherence to the filter can actually clog the machine more quickly, which is why you will actually see more clogging in CVVH of that filter. Your effluent pressure will be much higher. So it's kind of the expectation when using things like rhabdo in really septic patients, because you're actually pulling out the myoglobin in rhabdo, and septic patients, you're pulling out, those microclots. So you're going to have more, you're going to have higher effluent pressures. So you probably need to change the cartridge more frequently in those types of patients. So continue with CVVH. This is the removal of large volumes of fluid using ultrafiltration. Now, ultrafiltration can also be used in CVVHD, but again, that was more to remove the particles, where this is more to remove that fluid. So you will want to actually replace some of the fluid, because if you're removing all the fluid from the patient, they might be hemodynamically unstable. And that's where, the small and middle molecules are removed. And this is green to red, unlike CVVHD, which was green to green. Scuff is another mode we use, and this is also green to green, much like the CVVHD was. And this is no dialysate or therapy fluid, and a small amount of urea is removed, but this is usually for fluid removal. We see the word ultrafiltration, slow, continuous ultrafiltration. We'll talk about ultrafiltration a little bit more in upcoming slides, but we've used this a couple times just to remove fluid off patients. We've actually had a couple of heart failure patients over the last couple years in which we had to use scuff. Another mode is Crrt, and this is just prolonged intermittent renal replacement therapy. So what does this mean? If you look at this picture here, and I always like this picture because you could see this timeline here of 0 hours to 24 hours. Well, let's think we're putting a patient on IHD. Your dialysis nurses come in, they go in the 2 to 4 hour treatment because the patient is stable enough hemodynamically to have that fluid removed in 2 to 4 hours. Well, a lot of our patients, especially the ones that are in septic shock, they're not stable enough to be removing 1 to 2 liters of fluid in such a short amount of time. So we actually put them on the CRT, again, the continuous, that runs over a 24-hour period. Crrt is actually right here in the middle. So as our patients get better and are able to become more hemodynamically stable, we can go from CRT to IHD, but bridging them with this PERT. And PERT is usually a 10-hour treatment. And again, the bridging therapies. And this is also a green to green connection like the CVVHD. So electrolyte monitoring. One of the things I really like about Epic is the conditional lab orders if you want to really sure electrolytes. And there's actually details in all the comments as to how often to get a BMP. Now, this CRNP is actually part of the renal group. So these orders are coming directly from renal. When you get labs, well, you want to get labs before the initiation of CRT, get a good baseline going. And then at least every 8 hours is what the policy says. With scuff, because you don't have to do it as much, policy says 12 hours. Now, again, I mentioned if you are on 2K, it's going to be every 2 hours. And if you're on 0K, it's going to be every hour. Right. And these lines are to be given through these medications are preferred to be given through a central line. But again, if you only have peripherals, the only one that really can't be go through a central line is the calcium chloride. So over the last couple of years, we switched over to Tego caps. And with Tego caps, they're the ones that go on the end of your dialysis catheter. So these are changed every Monday and Tuesday or every 7 days, and they do stay on during treatments. They're less caps and more of a valve. One of the things that I've noticed is nurses not documenting their cap change. The cap change is done, like I said, every Monday, Tuesday, or every 7 days. A lot of our CLABSIs throughout the hospital system, at least 50% have been related dialysis lines. So they're really having the documentation of the valve change is really important when I go back and look to see, what may have contributed to a CLABSI. So there is no heparin in these; they're not heparinized, and you really do want to make this a sterile procedure when changing the caps. At least use a mask, and then you cover these with the white caps when not in use. Recently, probably within the last year or year and a half, we switched over to the ClearGuard caps. Now, the ClearGuard caps are different in that they are dead end caps, unlike the valves of the Tego catheters. But they also are coated with CHG on this long stick that kind of goes into the catheter. So when you put these on, well, you really want to put these on when the CRT is not in use, which is why we mainly go with the Tego caps, because we're usually not using these ClearGuard caps because, again, CRT is continuous. But if we're going from CRT and we switch over to IHD, in between IHD treatments, we really want to see these ClearGuard caps on. And these can actually be found in our storeroom. With the anticoagulation, there's two types. We have systemic and we have pre-filter heparin. So when we put heparin on a patient, if they're on heparin for, let's say, AFib, we want that going into the patient. We do not want that going through the machine. If the heparin is ordered pre-filter heparin, then it is to go before the filter. And I'll show you in the next slide exactly what port that goes through. Now, this blue cap, there's two of these that actually come with the CRT cartridge. You might even find these in the top drawers of some of the patient rooms because, again, every time you change a cartridge, you don't necessarily need one. So people just keep extras in that top drawer. And this is an anti-reflux cap. And what this is going to do is this is going to attach to the actually Alaris pump tubing. And then this is going to plug into the cycler. And I'll show you the port in the next slide here. So this is our basic CRT cartridge as of now. This is what it looks like. And you'll see this pre-pump T over here. This is where you're going to put your heparin into. All right. This port right here is going to be going to your access pressure line. This is going to be connected to your saline. And then the only other one that's open to put the heparin is this here. This pre-filter T over here is going to be, if you're doing green to red, you're going to be going green to red here, and green to green, you're going to be putting through here, which leaves this open. But again, all heparin should go through this filter up here. The 505 cartridge is a cartridge that we actually had as backup, but was actually put into circulation a couple times in the last 2 years. And the few differences between this cartridge and our regular cartridge are these needleless ports right here. And these needleless ports work the same way as that pre-filter T did, where you can actually hook your heparin up to one of these two ports. There are also post-filter ports. We do not use them. Pen policy says we really shouldn't be infusing anything post-filter into a patient. There's also these clips, and these clips are actually designed to be more secure. They're secure clips is what the company calls them. And that just kind of prevents any accidental disconnecting of the line to the patient. And this is actually the tip sheet from the company showing you the secure clips and also the needleless valves. So ultrafiltration. This is actually what your order is going to look like when it's put into the computer for CRT in general. The first thing you're going to see is the type of CRT you're going to be using. In this case, it's CVVH. You're going to be seeing your therapy orders, including your blood flow rate, which is how fast that blood is going to flow through that filter. Your therapy fluid rate, which again is how fast your dialysate is going to be flowing countercurrently with that blood, and also your fluid goal. Now, your fluid goal is going to be related to ultrafiltration. So when we talk about ultrafiltration, we see this order down here. Ultrafiltration is the amount of fluid we want to remove from the patient in a 24-hour span. So you might see an example like here of, okay, fluid goal is negative 1,000 milliliters. So they want to be negative 1 liter in the 24 hours that this patient's on CRT. Now, this calculation down here says, okay, well, if you want to be negative 1 liter, you want to set that UF rate at 42 milliliters an hour, plus patient hourly, which I'll talk about in a minute. In a future video, I will show you exactly how to change each of these settings on your machine. But for now, right now, we're just talking about the general concept. So for every milliliter of intake the patient takes, that needs to be accounted for in order for the UF goal to be reached. For example, let's say your goal is negative 1 liter, but your patient requires 2 units of packed red blood cells and 2 antibiotics totaling 1 liter. Well, your patient's starting the day already at positive 1 liter. So if you set this to 42 milliliters per hour and remove a liter in that 24 hours, then your goal for the day is only going to be at 0 when the goal is negative 1 liter. So it is okay to kind of titrate that UF rate to get to the desired fluid goal. Now, removing fluid will actually affect your blood pressure. So if too much fluid is being removed, the blood pressure may be affected. And in this case, you may want to come down on the fluid, removal, but also you really should anticipate using pressors because it's really important to meet that fluid goal for most of these patients. And we can always take the pressors off after we're done UFing. I like this sheet here, this graph here that shows the I's and O's. I know you guys do the I's and O's a lot more than I do. So maybe you have a sheet or maybe you have a picture that you like a little bit more. But if you look at this here, this actually breaks it up by shift. So 7 a.m. to 6:59 a.m. the next day. And you'll see the 24-hour I's and O's. Now, if you look at this patient here, they were removing about a liter a day. And you get total of negative 714. That's great. Well, then they ordered TPN on this patient, and the patient was getting a good amount of TPN, which means the patient ended up being positive 801 because the UF was never adjusted for that additional volume. Over the course of the time, you see the UF was adjusted. They removed, they had the UF set to remove 1.8 liters this shift. This shift, it's 2.6. So They went up on the UF to remove more fluid to accommodate that added fluid from the TPN, and the patient ended up being negative. Now you see here, the patient ended up getting a little bit more. They took a little bit of PO, probably through medications. I'm not really sure with this patient, but again, it added to the amount that the patient was taking in. Well, the UF, they were only able to remove 1.8 liters that day. So they really had to work hard overnight and ended up removing 4.2. In the end of that 24 hours, the patient was still negative 669. Okay. So this breaks it up from 7A from 7A to 7P. And this is 7P to 659A. The CRT flow sheet. So this has changed a little bit in the expectations over the years. Attached to this piece of education, this video, I have the direction on how to associate devices, and device data must be updated every single hour along with pump rate verify. It's really important with these patients that we're documenting eyes and nose every hour, and we do that through flow sheet association and also pump rate verify in the MAR. So also, please make sure patients do not have two devices associated with them and disassociate a device if necessary. In addition to this, your CRT treatment type with should be automatically or should be placed in the flow sheet at least every 24 hours. So this causes an automatic charge. So if you put this in, this is ensuring that the patient is charged for the CRT. And again, it should be documented. There were a couple of times where the patient wasn't charged for 4 or 5 days for their CRT because this wasn't done. So again, the most important thing about this is making sure that you are documenting the UF, documenting the intake through your MAR every hour, and again, making sure that they're associated correctly so that you get the pressures and everything else from an accurate number. If you do have any questions about associating devices or anything that you saw in this video, please feel free to reach out to me, okay? And again, there will be more education forthcoming in terms of the actual machine itself, priming, and troubleshooting.